So good night guys, this is Akash Sijad and now time is 2 a.m. Okay, so we are going to learn about staphylococcal infections. Many people teach staphylococcus aureus in YouTube only, but it was not so much deep and they missed so many points. Okay, so I have tried to cover each and every point, so please stay until the end of this video and take grasp as much as things possible. Okay, there are two, one is staphylococcus, another one is streptococcus. Okay, both are a little confusing, but they can be easily differentiated by catalase test. Okay, staphylococcus infections. Staphylococcus, these are gram positive cocci. They are divided into two types of family, that is micrococcaceae family and streptococcaceae family. Micrococcaceae families, these are catalase positive. Okay, and they are divided into micrococcus and staphylococcus. Micrococcus forms the skin, they are the skin commensals, and the another is streptococcaceae family. These are catalase negative. Okay, streptococcaceae family are the catalase negative and micrococcaceae family are the catalase positive, and our staphylococcus comes in micrococcaceae family. Okay, now coming with the staphylococcus aureus, which is one of the most common, most harami, means it is one of the worst bacteria. Okay, in microbiology. Staphylococcus aureus, it is a catalase positive, coagulase positive, and facultative anaerobe, non-motile and non-sporing. Catalase positive, coagulase positive, facultative anaerobe, non-motile and non-sporing. It is a spherical cocci, gram positive, arranged in a cluster, grape-like bunches. Okay, grape-like bunches means it is a gram positive bacteria arranged in cluster. Gram positive bacteria arranged in cluster, and it forms golden yellow pigmented colonies on nutrient agar and beta hemolytic colonies on blood agar. Always remember, it forms the golden yellow colonies on nutrient agar. You can see here it forms the golden yellow colonies on the nutrient agar. Okay, golden yellow colonies on the nutrient agar, and it forms the beta hemolytic colonies on the blood agar. Beta hemolytic colonies on the blood agar. Always remember, golden yellow colonies on nutrient agar and beta hemolytic colonies on the blood agar. It is the most basic things you should know about staphylococcus. Now coming to the virulence factor. Virulence factor, as you already know, our this staphylococcus is a gram positive. Okay, for gram staining, what are the characteristics of gram positive? It should have a thick peptidoglycan layer, and it should have teichoic acid in the cell wall, and these are the basic things for gram positive. Okay, from that only you can derive the virulence factors. One is the cell wall associated antigens, like peptidoglycan is thick, teichoic acid is present, cell surface adhesions, clumping factor like protein A, and next is microcapsule. The microcapsule and protein A are responsible for antiphagocytic activity. Okay, means they are not phagocytized by the neutrophil and macrophages. Next, coming to the toxins. Toxin is another virulence factor. It forms the membrane action. Toxins are hemolysins, that is alpha, beta, and gamma and delta. Okay, another one is leukocidin. These are cell lysins. Means the toxins released. These toxins are released by the bacteria, which causes the lysis of the cells, the lysis of our cells. Okay, and forms injury to our cells. And next is epidermolytic toxin, which causes epidermolytic means it causes skin. Okay, next is enterotoxins, GI wala. Next is toxic shock syndrome toxin. We will discuss this in upcoming. Okay, next is extracellular enzymes like coagulase, heat stable thermonuclease, deoxyribonuclease, staphylokinase, that is fibrinolysin. Next is hyaluronidase and lipase and protease. Okay, these are the virulence factor. Go through them. Now coming to the pathogenesis. First, there is colonization on the body surface and introduced into tissue by the abrasion and instrumentation, adherence, invasion to the local spread, evasion of the host defense mechanism, metastasis spread to the distant site. Okay, first the bacteria colonize in a body, and there is abrasion, they enter into our body. Okay, from the abrasion means any type of injury, they will come into our body, and then they will adhere to the our surface, and there is invasion, and they start multiplying. Okay, and from multiplying they spread to the different parts of our body. Okay, this is the pathogenesis. Clinical manifestation, they form the most commonly skin and soft tissues, that is folliculitis means inflammation of the hair follicles. Next is furuncles means they are form of boils. Okay, next, what is carbuncle? When these furuncles are connected, okay, imagine this is one furuncle and this is one furuncle, and they will be connected from below, okay, and they will be connected from below, means the one bus they can travel to this, okay. This is carbuncle. Next is abscess. You already know abscess. Next is impetigo, cellulitis, hidradenitis, okay. Next, musculoskeletal infection like septic arthritis, osteomyelitis, pyomyositis, and psoas abscess, okay. Osteomyelitis is one of the important question, okay. We will cover it soon in pathology. Next is respiratory tract infection, that is septic pulmonary embolism, pneumonia, empyema, ventilator associated pneumonia. See our video which is on ventilator associated pneumonia. It is a 5 marks important question. Next is bacteremia. It forms sepsis, septic shock, and bloodstream infection. Another is urinary tract infection, that is pyelonephritis and catheter associated infection, okay. These are the clinical manifestation of staphylococcus aureus. Skin and soft tissue, musculoskeletal, respiratory tract, urinary tract, and bacteremia. Now coming to the laboratory diagnosis, okay. We will go with a simple, like first there is sample collection, then we will do direct smear, then we will try to culture it. After culture we will do biochemical test, antigen detection, then antibody detection, molecular methods, okay. Let's start laboratory diagnosis. Sample is pus, wound or swab, sputum, midstream urine, blood, feces, next contaminated food, vomiting, etc., okay. Everything which causes infection, means like patient came, that particular sample will be collected. Then we will do direct smear microscopy of that sample. We will see gram positive cocci arranged in clusters. Gram positive means they will occur as purple color, okay. Purple color cocci arranged in clusters. On culture, I already said it forms circular smooth, convex, opaque, easily emulsifiable, golden yellow, non-diffusible pigmented colonies, okay. And on agar slope, oil paint appearance of the staphylococcus aureus is seen. On nutrient agar it forms golden yellow colonies. On the blood agar it forms beta hemolysis on the blood agar. And on McConkey agar is a differential media which differentiates McConkey agar differentiates between lactose fermenters and non-lactose fermenters, LF and NLF. Lactose fermenters occur as pink color, okay, and PINK, and non-lactose fermenters occurs as pale color, okay, PALE, pale. These are lactose fermenters, therefore they occur as small pink color colonies. Liquid media is peptone water, that is uniform turbidity is in. Selective media is mannitol salt agar, milk salt agar, and Ludwig's medium. Then we will do culture smear microscopy. We can see gram positive cocci in clusters. They are non-motile by hanging drop, okay. Now what is hanging drop? Imagine this is a slide and there is some dent is given in the slide, okay, this type, and a cover slip is placed like this, okay. Here this slide a drop, the one which is shade is like a drop, okay. When and microscope is seen like this. From here the microscope is seen, so the bacteria will be motile here, okay. From motile here we can see the hanging drop method. Biochemical test is catalase positive and coagulase positive, okay. Staphylococcus is both catalase positive and coagulase positive. Antigen detection is by protein A detection, that is latex agglutination test. The one which you are seeing here is a coagulase test, okay. Coagulase test, it is of two types. One is tube coagulation test and is slide coagulation test. Tube coagulation test is done for free coagulase, okay, free, and here it is done for bound coagulase. Slide coagulation is for bound and this is for free coagulase. Bound means it is bound, it is free bound, you will understand later, okay. Next is automated systems like Malditov and Vitek. It is a common thing. Molecular methods like PCR can be done, and bacteriophage typing can be done. Next, antimicrobial susceptibility testing by disc diffusion method, that is Muller-Hinton agar. Another one is MIC detection, that is minimum inhibitory concentration, okay. Drug resistance, that is introduction of beta lactamase enzyme. Drugs is one of the important thing. They will ask the mechanism of drug resistance, okay. Commonly staphylococcus aureus comes as a clinical condition. Most commonly, like they will take a cellulitis only or any other infection, and they will ask how is the drug resistance, okay. Drug resistance is by introduction of beta lactamase enzyme. I will tell. And there is alteration of a penicillin binding protein. One is beta lactamase enzyme, another is penicillin binding protein, and there is MRSA, methicillin resistant staphylococcus aureus. Remember this, and it causes community acquired and hospital acquired infections. Okay, hospital acquired infection is also known as nosocomial infection. Coagulase negative, there one of the most important viva question is coagulase negative staphylococci. Name some coagulase negative staphylococci. That is Staphylococcus epidermidis and Staphylococcus saprophyticus. This most important are these two. Remember them: Staphylococcus epidermidis and Staphylococcus saprophyticus. Initial adhesion to the prosthetic device, colonization and formation of biofilm manifest as endocarditis and stitch abscess. Okay, this is Staphylococcus epidermidis, and Staphylococcus saprophyticus cause urinary tract infection. These are other two are hard one. Remember, coagulase negative staphylococci are Staphylococcus epidermidis, Staphylococcus saprophyticus. This is the most important viva question. Okay, how is the mechanism of resistance? Okay, production of beta lactamase enzyme. This is the beta lactamase enzyme. This enzyme degrades the beta lactam ring, which is present in antibiotics. Okay, the beta lactamase enzyme degrades the beta lactam ring present in the antibiotics. Thus, the action of antibiotics is lost. Thus, the bacteria shows resistance against those antibiotics. Okay, so when we will give beta lactamase inhibitors such as sublactam and clavulanic acid, these sublactam and clavulanic acid inhibit this beta lactamase enzyme. Okay, sublactam and clavulanic acid inhibit this beta lactamase enzyme. Thus, the action of beta lactamase is lost, and there is no degradation of this beta lactam ring. Thus, the beta lactam antibiotics can kill the Staphylococcus aureus. Okay, this resistance against is by transduction. Okay, transduction, plasmid coded. Now you can see important question MCQ type. Beta lactamase enzyme resistance to against penicillin. Okay, mutation in the MECA gene converts a penicillin binding protein into penicillin binding protein 2A. Thus, there is formation of MRSA, that is methicillin resistant Staphylococcus aureus. Mutation in VAN-A gene causes vancomycin resistant Staphylococcus aureus. And vancomycin intermediate Staphylococcus aureus is by increase in the cell wall thickness. Okay, these are the four main things like mechanism of resistance: production of beta lactamase enzyme, mutation in the MECA gene, and mutation in VAN-A gene, increase in the cell wall thickness. Okay, let's revise once again with laboratory diagnosis. First, we will do direct smear. We can see gram-positive cocci arranged in clusters. Nutrient agar, we can see golden yellow pigmented colonies, and on blood agar, we will see narrow zone on beta hemolysis. Selective media are mannitol salt agar, milk salt agar, and Ludwig's medium. Culture smear microscopy is gram-positive cocci in clusters. Biochemical tests, these are catalase positive, coagulase positive. Okay, and antigen detection, you can see protein A detection by latex agglutination test, and automated system like MALDI-TOF and Vitek, antimicrobial susceptibility testing, that is Muller intern agar. Let's cover in this video only. I thought it to make another video. Toxic shock syndrome toxin. Okay, toxic shock syndrome is a syndrome means a group of diseases. Okay, it is caused by toxic shock syndrome toxin. There are two types of TSSC, that is TSST1 and TSST2. Okay, these are super antigens. I will tell. TSST1 is a Staphylococcus enterotoxin F. Okay, TSST1 rarely enterotoxin B and C, maybe also. Risk factor is initially toxic shock syndrome was reported in the women who are highly absorbent vaginal tampons during menstruations. Okay, initially toxic shock syndrome was seen in women who use vaginal tampons. Okay, later it is also seen in Staphylococcus abscess, osteomyelitis, postsurgical trauma cases. Okay, and burn and wound infections. Pathogenesis: TSST1 get absorbed into the circulation from the tampons. Okay, from vaginal tampons, that bacteria comes inside, and it is a releases toxin, that is a super antigen, stimulate the T cell directly. Okay, let me tell you, this is an antigen presenting cell. When antigen binds to the antigen presenting cell, this antigen presenting cell transfers it to the T cell. But as the TSST is a super antigen, they directly bind to the V beta region. Okay, and stimulate the T cell. They do not require antigen presenting cell. Okay, they do not require antigen presenting cell because they directly bind to the V beta region. They are super antigens, they bind to the V beta region of the T cell receptor. V beta region of the T cell receptor and stimulate the T cell. Okay. Clinical features of this TSST are fever, hypotension, mucosal hyperemia, vomiting, diarrhea, confusion, myalgia, abdominal pain, erythematous rashes, desquamation, later subsequently rapid involvement of other parts. You remember this hypotension, okay? I will tell. TSST1 is enterotoxin F, super antigen V beta region of T cell receptor. Case definition is by clinical criteria: fever, rash, desquamation, hypotension, multi-organ failure, multi-organ involvement. Laboratory criteria is negative blood culture for pathogens. As there is a TSST toxin, okay, toxic shock syndrome toxin, antibodies are formed against that TSST, that is anti-TSST antibodies are formed. We can use PCR for also that lattice agglutination test and enzyme assay. Okay. Now coming to the treatment part of toxic shock syndrome. As there is capillary leakage, okay, capillary leakage, there is formation of hypotension. Thus we should give large amount of fluid to the patient. Okay, and we should remove the vaginal tampon, which is a major source of release of this toxin. Okay. Next we should give clindamycin is a preferred drug for toxic shock syndrome, and we can use cloxacycline for MSSA, that is methicillin susceptible staphylococcus aureus, and we should use vancomycin for MRSA, methicillin resistant staphylococcus aureus. For clindamycin resistant cases we can use linezolid. Okay, linezolid can use for toxin suppression. Okay, with this we have covered staphylococcus. Okay, I have covered each and every point of staphylococcus. I hope you like this video. Please like, share and subscribe. And I have made a very detailed video of staphylococcus. It took more time to prepare all the content also. Okay, please share Medcommon India and take subscription of our channel. Share this video in your YouTube channel, means share in your batchmates, your best friends. Okay, see you in the next video. Until then, Jai Hind, Jai Bharat. This is me, Akash GZ.